This is chapter 46, Professor.
Page 161.
Page 161. Okay, thank you.
All right, people who cannot receive adequate nutrition via the oral route, the usual way we get our nutrition by eating and drinking, will have to be evaluated for artificial nutrition, or we call this other feeding modalities. Now, the goal, of course, is to meet as close to 100% nutrition as possible. As to which form or which route to use will be dictated by the patient's needs and the patient's condition. So if the patient, for instance, has any GI problems affecting their either ability to swallow, chew and swallow, or their ability to absorb the nutrition, in which case this could be any patient with oral problems, like say you're receiving chemotherapy and radiation specifically to your neck, for instance, or your head, more like the face and the neck. So your ability to swallow is severely impaired, if not impossible. So patients who have difficulty swallowing, difficulty chewing, will have to receive artificial nutrition. Let's go first with the TPN, which is the IV route. This would mean that the patient has a GI tract problem impairing their ability to swallow or, again, absorb the nutrition. So this could be patients who've lost their stomach, no more small bowels, for instance. It could also be if it's unsafe for them to receive anything via the GI tract. So here comes total parenteral nutrition. It could also be partial. There is something we call partial parenteral nutrition. The difference between the two is with total, meaning that the patient's entire intake is only given via the IV route. If it's partial, meaning the patient still eats by mouth, partially, obviously it's not enough to sustain life, so they still receive IV nutrition. So, but since it's not 100%, so that's why we call it partial. The concentration of the solution is also different. The total parenteral nutrition, since all of your nutrition is depending on this IV solution, the concentration of your carbohydrate, of course, is higher. So this one will require 10% or more of dextrose. This will be your main carbohydrate content, is the 10 to 20% dextrose. The proteins will be provided by amino acids. And finally, your fat will be in the form of lipids. I know it says here that lipids can be contained in the primary TPN solution or infused separately. I actually have never seen it combined with the primary TPN. The primary TPN will only contain your dextrose and your amino acids. The lipids are usually infused separately because lipid emulsions are different. I don't think they're compatible with the amino acid solution. So it usually appears like a milk bottle. So lipid emulsions are either in polyvinyl bags or in glass bottles. It looks like milk when you infuse it. There are also trace elements in there, micronutrients like your electrolytes. These are all mixed in by the pharmacist. The doctor gives the order about how many calories the patient requires, and he just checks. It's just a checklist. He just checks the boxes what he wants in there, and then he'll add how much, especially if the patient has any kidney or any other problems that they need certain amount of electrolytes or vitamins that need to be restricted. So the doctor specifies that in the order. Insulin may also be added into the solution, especially if the patient is diabetic. It's just because of the some non-diabetic patients may also receive insulin in the bag. Okay, it's already added into the bag because of the high concentrations of the dextrose. So in that instance, it may overwhelm the body, wherein the body will be unable to keep up with the insulin secretion, because the TPN, because it's TPN, will run for 23 hours a day. I mean, it's continuous. Unlike you and I, wherein we can eat 3 times a day with snacks in between, when you put it in the IV solution, there's no such thing. We can't give a bolus anymore and then do the feeding 3 times a day also. It can't work like that, because this is now artificial nutrition. So we lose the body's natural physiology, wherein we eat, food sits in our stomach for 1 to 2 hours, and then it while it sits there, it's turned into liquid, and then it slowly enters the small intestine and then finally into the colon. And then we repeat that for breakfast, lunch, and then dinner. And like I said, we have snacks also in between. So we lose that physiology. So now we have all your nutrition given IV. So therefore, we can't give them boluses, because this is now, there is no need for the body to break this down. So imagine how much sugar we're talking about if we're going to give bolus feedings IV. So it's just not possible. So the only way to give this is slowly over 23 hours a day. There is a 1 hour break, because you have to change the tubing, you have to change bags, you have to do, the patient has to do hygiene. The patient also has to, well, not the patient changing the dressing, but the nurses will have to inspect and then change the dressing, because the route here is IV and this is high concentration, so it has to be a central line. We've already discussed central line in our virtual labs. So we have ports, we have PICC lines, we also have central catheters for that purpose. The partial parenteral nutrition can be given through a large peripheral IV, large gauge peripheral IV, or a midline catheter. However, if it's TPN, because of the concentration of the solution, there's no way this will go through a peripheral line. It's just too thick. It won't run even if you use a pump. The main thing here is you're dealing with 2 highly risky therapy here. One is the infusion itself, because imagine how sweet 10% or even 20% dextrose is. Will that attract bacteria?
Yes.
All right, I know it would attract me. So let's say I'm a bacterium. So I'm not only attracted to the 10 or to 20% dextrose solution, but also the route. Meaning I don't have, imagine entering the body without having to go through stomach acids, you know. There's no need to go through pain, enduring being in the stomach exposed to that acid. So I have free entry here. I go directly into the bloodstream without having to go through all that pain. So I'll enter through the central line, and then here's really rich food being provided. So the patient here, the number one complication really is sepsis. Patient will have a blood infection because of the IV solution being used, and also the route, which is a central line, a really large vessel, very easy to enter, and then lots of food for me, so I can easily multiply and cause problems. Because of this reason, there is no extended use for tubing. So the tubings, the bag, if there's anything left over, for instance, everything has to be changed in 24 hours. So the tubing, the bag, whether or not we finish the bag, because things happen during the infusion, the pump fails, the tubing gets kinked, or the line gets clogged. So of course that will cause a delay in your therapy. So the patient may not get the whole 100% nutrition in a day because of all these setbacks. Okay, so things can happen during the infusion, or let's say there's an emergency where the patient, you can't hook up the patient to the feeding yet, to the TPN yet, and then the patient has to go somewhere. Any reason. So there are a lot that can happen during the therapy, wherein the patient won't get the whole nutrition. One thing to remember is you can't play catch up, because it's already calculated about how much you're infusing per hour. So if the rate is, let's say, 50 ml per hour, you cannot switch that and then play catch up. So let's say you're behind 2 hours, so you can't increase the rate in order to catch up, because that will result in a really high blood sugar. And the TPN solution already contains insulin in there, adequate for only a 50 ml per hour rate. So therefore, if you increase the infusion, then that means the patient could go into severe hyperglycemia. So TPN, both again, the bag and the administration set should be changed every 24 hours. The set will already include a filter because of the thickness of the solution. Again, there might be larger debris also in the solution, so just in case we get those, it will be caught in the filter. So this is the reason why we need a central line, because we don't want any phlebitis, because this is the reason you cannot give it through a small peripheral vein. It has to be a large vein. There's not enough. There's another reason here is hemodilution. So there's not enough hemodilution if you give it in a small peripheral vein. Given the high risk for sepsis and septic shock and death, it's really educating the patient about infection control, how to care for the line. Of course, the patient here is the main stakeholder. It's their life that's at stake here. Nutrition plus they should know the complications of the therapy, which again is very serious, sepsis. So they are actually more involved usually, unless they are at a point where they just don't care anymore. But most patients I've taken care of, they're very protective of the central line. They watch you like a hawk when you prepare the solution, spike the bag, infuse it. So if you don't know what you're doing, don't pretend like you do, because these patients, unless it's their first time, cannot be fooled. These patients know exactly how things are supposed to be done, especially if it's a parent or a spouse or a child, for instance, of the patient. They are, so just be prepared to be really scrutinized, okay, with your infection control, because they can be very protective of the patient. because we cannot care for these patients 24 hours a day in the home, there is and then these patients also have to go on with their lives. The last patient I had with this, she had a total, she basically doesn't have small intestines anymore. She lost it to cancer. She has a stomach, but because of these changes, I mean, you go from your stomach down to your colon. She has no ability to absorb nutrition. So she's been on TPN for a long time. So she was a type A person, a chief executive of a company. She's the one that goes to work in really these sharp, fancy blazers and executive clothing, because she's a big honcho. She has a TPN. That's how she lives, and she just carries a bag with her. Of course, it's the one issued by the pharmaceutical company is a backpack. You can't wear a backpack wearing a nice blazer, right? So she just carries it on her hand, and that's how she gets around. It's a big bag. It's a 2-liter bag. So that's quite heavy. It gets lighter at the end of the day because it's already infused inside the patient. But that's how she lives. She passed away probably 3 years after, and she died from sepsis. So somebody made a mistake, either her or probably a nurse at some point, but it's inevitable. If you live like that, it's really high risk. Some days, at some point, you're going to get somebody's going to make a mistake, and then somebody will cause sepsis to the patient. So these are your teachings. Believe me, again, the family members and the patient will be very careful with the aseptic technique. You should also tell them about what are the expected, but most especially the unexpected signs and symptoms to report, namely signs of infection, because it may be local. Sometimes it may start local, but then sometimes it may also go straight systemic. So teach them about signs and symptoms of local versus systemic infection. And then whenever the dressing over the central line is compromised, in which case it's impossible. You cannot delegate changing the dressing to a family member. It has to be a nurse performing the dressing. So there's only one thing to do, is to call the clinic or the office, call the hospital to have somebody come over and change the dressing. If, let's say, something happens, remember what happened in the last storm, for instance, either here in New York or down in Florida, Georgia, for instance. Have you ever been in a situation wherein the roads were impassable? They're inaccessible. Pretty much city services came to a halt. There's so much damage that nobody can go anywhere. There's no power, like Hurricane Sandy, for instance. Do you recall that time?
Yes.
Okay, so there will be scenarios like that wherein the patient will have no access to TPN. So what are they supposed to do? Just go in a corner and die? All right, so there will be instances wherein they will run out. Their TPNs are usually 1 or 2 week supplies worth. So they get deliveries every week. So in cases like that, wherein logistics is a problem, so the patient will have a backup. So they will always have at least a week's worth of 10% dextrose, meaning if they ever run out of their TPN, they have to be kept alive with at least carbohydrates. So they will have a standby box or a few boxes of 10% dextrose. So every time they run out and it's impossible to get TPN, they will just have to hang 10% dextrose, okay, in the event of an emergency. So they will have a backup supply, just like how you guys, when we know, just like when the pandemic started, right? When we first shut down, everybody was buying toilet paper, and the shelves were emptied. So kind of like that scenario. So these patients will also have the same. The only thing they need, though, I mean, they can't eat anything. So all they'll have are these 10% dextrose bags. So this would be their source of nutrition, at least carbohydrates. You can live without protein and fat for a while, but you can't go without carbohydrate for 24 hours. You'll start wasting away. And that's basically it for IV nutrition. So your number one problem here is infection, and of course key to prevent that is to maintain aseptic technique, both in preparation of the solution as well as caring for the IV line. Any question? Let's go now to enteral nutrition. Go to page 810. This would be under Guillain-Barré because that's where the textbook put it. All right, Guillain-Barré syndrome patients may need enteral nutrition. So it's all on this tiny box right here. Have you ever done this in lab, the tube feeding, or in clinical in the nursing home?
Yeah.
No.
All right, some said yeah, some said no. Okay.
Did it in the nursing home.
All right, so who gets nasogastric or peg tube feedings in your opinion? So can these patients chew or swallow safely?
No.
No. Okay.
No.
So every time the patient is unable to chew
But
or
they still have
swallow,
part of the GI support.
yeah, the GI tract is otherwise intact. It's just the manner of chewing and swallowing that's impaired. So let's say you got mugged, okay, or you lost your teeth, or you had somebody smashed your head with a hacksaw, for instance, okay, or your jaw is broken, right? So you can't swallow, you can't chew, you can't swallow. Or let's say you are intubated, you're in the hospital, you're in the ICU, you are intubated, you're sedated, so you can't eat, so we put you on enteral nutrition. As long as the GI tract is available, we try to give the feeding via the GI tract. Now, why is that? Why can't we go TPN? We just concluded TPN. Why force enteral nutrition? Why not go TPN?
I guess because it's long term, and with TPN you don't want to be running it long term because it could cause bacterial infection.
Okay, very good. There are higher risks associated with TPN, obviously. We just concluded that discussion. So in TPN, it can kill the patient. So the number one example, I gave you an example of that very nice lady I took care of. So she died eventually. She was young. She was in her late 40s. She wasn't even 50 yet. So sepsis got her eventually. Okay, and she was, I mean, she's educated about that. She knows enough that that was the risk, and she chose to, how else are you gonna live, right? But as long as the GI tract is available, we use the GI tract for nutrition because that's how it's supposed to be. Hey, nature intended for us to eat, and that's how we get our nutrition by mouth. In this case, in this instance, only the upper part is unavailable. So we have there's no ability to chew or swallow. So we put the feeding straight into the stomach. Okay. Or if there's a stomach problem, then we put the tube straight into the duodenum. Okay, whichever case, this is enteral nutrition. Let's watch a short video on how a peg tube is inserted. In case you guys work in a nursing home, because things happen, patients pull the tubes out, you should be able to know how to replace it. Can you see the YouTube video?
Yeah.
Yeah.
Okay, when we say extended period of time, just like Janessa said, this is for long term. If it's short term, under 2 weeks, for instance, the tube will have to be a nasogastric tube. The doctor will insert it, or nurses can also insert nasogastric tube depending on the state. Down in Florida, we're able to insert feeding tubes. So the key here is again, how long is this expected to occur? So if it's long term, then it will have to be a PEG tube. It has to be a PEG tube or a gastrostomy tube. All right. So take note that there was no incision made here. It was just a needle, right? So the only thing keeping the thing open is that hole. Are you with me so far?
Yeah.
Okay. So therefore, there's a track here that's created by the tube, and the only thing again keeping the track open is that tube. So what will happen if we pull the tube either intentionally or accidentally, which is what happens in the nursing home? So these patients are confused. They pull the tube, or let's say something happens, the tube was pulled out. Does the track remain open?
Probably not, being that there was no incision
No.
made to begin with.
Okay, so probably not. Plus, was there only one surface involved here? I mean, between the stomach, the inner lining of the stomach, to the abdominal wall, how many layers of tissue are we talking about here? So we have the stomach, we have two sides of the stomach, then we have the visceral and the parietal, and then over this there's a peritoneum, right? There's the peritoneum, a thin sheet, and then after that you have the muscles. Okay, we have the abdominal muscles, and then we have the fascia over the muscle, and then we have subcutaneous fat in between, and then we have the hypodermis, and then the dermis, and the epidermis. So how many layers did I just talk about? Easily six or more, right? So were they aligned properly during the insertion? And do they remain aligned forever? Of course, this patient was in the OR and the endoscopy unit when this was inserted. So they were laying flat. Okay, they were flat and steady. So yes, at that point the stomach was aligned. But whenever this is pulled out, is the patient are the tissues aligned still in the exactly the same alignment during insertion?
No.
No, so again, the only thing keeping this track open, the hole in the epidermis, the dermis, the subcutaneous layer, the fascia, the muscle, the peritoneum, the stomach, is the tube. So the tube's gone. What will keep them open then? What will keep the track open?
Wait, can you repeat that, Professor?
It's a simple question. What will keep the track open if the tube is now gone? If you pull out the tube, what will keep the track open?
You gotta put something in there,
That's
like a catheter to hold it.
Okay, so the point here is very good. The point here is you don't have much time. The track begins to close within a few minutes. So once the patient pulls out the peg tube, you only have a few minutes in order to insert something else there in order to keep the track open, to keep it from closing. Because otherwise this patient will have to undergo another expensive peg tube placement back in the hospital. Is that clear? So you'll just have to insert something there, a gastrostomy tube, for instance, or a Foley. Sometimes you can also put in a Foley just to keep the track open until the doctor comes in and replaces it. Okay, at least the track is open. Now, only a doctor can insert a peg tube. I mean, you saw this video. It's clearly done in the endoscopy unit. A doctor performs it. So we cannot replace a peg tube. You saw how it was inserted. We need an endoscope to pull this thing into from the stomach out into the abdominal wall. I won't show you the rest of the video because the other video is just going. And you know what? Let's play the rest of the video. Okay. In this instance, since this is now a gastrostomy tube, all right, so this one you can insert this yourself. However, you need to still send the patient to the ER in order to get confirmation, because you don't know, you can't see inside, you don't know where the end of the tube is. So this is called a gastrostomy tube. Looks really different from the PEG tube that you saw in the first method. So this one is a gastrostomy tube. So since it was inserted by pushing it in, you can also do the same without the endoscope. So there's already a track, so the patient pulled it accidentally, so you have a few minutes, so go in there and then insert a new one. There are replacement tubes in the station. You always have one, because this is a frequent event in hospitals or nursing homes. So the patient pulls it, you have to insert it into the track as soon as possible. Of course, if you're unable to insert it, then don't force it. Okay, but you do have a open track, still open for a few minutes. So you will insert it, and then once you inflate the balloon, you send the patient to the hospital. That would take longer, because it's a non-emergent situation, so the poor patient will have to sit in the ER, wait their turn for the gastrograph and x-ray. So the doctor will order an x-ray after injecting a gastrographin solution. It's a solution that will show up on x-ray. So if that shows up on x-ray that it's in the stomach, then they'll send your patient back to the nursing home or back to the home, wherever this patient is. All right. So now we have a feeding tube. So let's go now to what do we do with the feeding tube. First responsibility is to make sure the patient's PEG tube or gastrostomy tube is in the right place. So most of the time before you use it, you have to confirm placement. Each and every time, there's no exception. So even if it's one shift, so let's say early in the morning, you already confirm placement. I already checked placement. Why do I have to check it again? Well, you have to, because are you sure that the tube didn't move between the last time you used it to now? So let's say you used it 4 hours ago. It's the same shift. Do I have to check it again? Yes, you do. Every time you use it or intend to use it, so you have to verify placement. So it's here. The nurse is responsible for verifying NG2 placement after insertion, before medication administration, and every 8 hours with continuous feedings. So when do you verify placement?
Every 8 hours.
Okay, so you know how to answer that question. Okay, the answers are here. Now let's go to the methods. How do we verify placement? All right. First is but it's not a guarantee. We put a mark if it's an NG tube. We put a mark at the nose, where it was where it exits the nose, because this is a NG tube that we're using. There's also the auscultation method. Have you done this in lab, wherein you listen for a whoosh? Have you tried that?
Yes.
Okay, so we call that air insufflation. Air insufflation using 30 ml of air pushed via a syringe, and then we listen over the stomach. And finally, analysis of gastric contents. So these are the traditional methods. So we look at the marking at the nose using the air insufflation, and then analysis of gastric contents. However, what does it say here? Because this is a evidence-based box. So what does it say right here? Thank you for reading, Mr. Richard.
It says the literature supports that insufflation alone is not adequate.
Okay, so listening for the whoosh like this is not adequate because they've discovered that even if the feeding tube is in the esophagus, when you put air into the stomach, you can still hear it even if the tube is in the esophagus. So there's still an echo that you will still hear it over the stomach. So therefore, that proves that air insufflation does not verify placement. It's not adequate. Do we still use it? Absolutely. There is still this practice, especially in long-term care. We cannot get rid of it. But just be aware that should you choose to use this method, that it is not adequate. Thank you for reading the rest, Mr. Israel.
Although there are many methods by which tube verification may be accomplished, example, pH, enzyme, bilirubin, and carbon dioxide testing, none of these methods allows detection of a tube in the esophagus or esophageal junction.
Okay, so there's really no guarantee. However, the most accurate is, although an X-ray, because there's a radiopaque lining on the tube, which will show up on X-ray, therefore telling you where it is. Can we do X-ray every time we use the tube? I mean, how many X-rays are we talking about here? 25 X-rays a day?
Not just one time.
Yeah, so it's not practical, right? So therefore, just be aware though that none of these guarantee 100%. But between air insufflation, which again, evidence shows that even if the tube is in the esophagus, you still hear the whooshing sound in the stomach. However, your pH, for instance, is plus the CO2, the presence of CO2. So does the stomach have an acidic or alkaline pH?
It's acidic.
Acidic.
Okay, very acidic. So therefore, can you rely on testing the pH of your residual when you aspirate for stomach residual?
Yes.
Yes, that's better than the air insufflation, right? Because the problem there is, what if the patient's stomach pH is not acidic at that point when you tested it? Say the patient's on antacids, for instance, or they're on H2 receptor blockers, which will increase the pH. So that could be a factor there. What about CO2 testing? Is CO2 present in the stomach or in the esophagus or in the trachea?
Yeah.
Yeah, it's in the lung, right? So we normally detect CO2 levels in the trachea. So therefore, if the tube, you put a capnometer there, a capnometer sensor, it's a device that detects CO2 levels. If you put it at the tip of the tube and it detects low levels of carbon dioxide, where is the tube? Is it in the stomach or is it in the lung? If the CO2 levels are high or normal, at least normal, where is the tube? Hello?
The lungs.
Okay, it's in the lungs. If it's low, of course, that indicates that where else could it be? It's in the esophagus or in the stomach. But again, the best evidence shows that only X-ray will confirm placement reliably. But again, we cannot do that 30 times each day, every day. So therefore, we're just gonna have to be content with the available methods. But again, I'll let you choose because your facility will dictate anyway what procedure they will use or employ in order to check or verify placement of your feeding tube. whether it's air insufflation, whichever one you feel is most comfortable. But of course, you have to comply with your agency policy. But for me, if this is what the agency policy says, I would still insist on doing this, checking my pH or my CO2 testing. Capnometers aren't expensive. I mean, well, it costs money, but now we can buy pulse ox cheap, right? So capnometers should also be, the cost should also be going down as well. And that's it for tube readings. Not mentioned here are how often, so just put it in your notes. So how often do we change the feeding set? You know, the tubings for feeding set?
24 hours.
Okay, also every 24 hours. What about the irrigation, the syringe that you're using for administering medications, checking placement?
Every time you use it.
Okay, 24 hours as well. What about if, because there are two methods here, we can use an open method or a closed method for feeding. Okay, an open method means you are the one preparing the solution. So for instance, let's watch this short one. Okay, so this is now the open method. So you can have one bag, or you've probably seen it if you observed in our skills lab. We have one that has a twin bags connected to the same tubing. That would be, one is for feeding, the other one is for water, because we all need water, correct? So therefore, this is a clean technique because your stomach is clean, it's not sterile. So, but I wouldn't hold it like this with her bare hands, like this one. Of course, she's only doing a demo, so that's why she's touching that with her bare fingers. So this is the open method. So you put the feeding literally in the bag. Now, the question is, the bag is capable of over a liter. How much will you put in there though when you are giving a feeding? Do you fill the bag up all the way to the top?
No,
How much will we put in there?
can be 7 milliliter.
The basis here is your rate of infusion. So if the doctor orders the feeding to run at, let's say, 60 mLs per hour, you can only put 4 hours worth. Anything beyond 4 hours will promote bacterial growth already. So you cannot put feeding in there worth more than 4 hours. You should only put 4 hours worth of feeding. So again, the amount will depend on the doctor's order. So if the doctor orders 60 mLs per hour of infusion, so therefore, how many mLs will you put in the bag?
240.
240, very good. And then when it's empty, then you put another 240 in there, and then another and another. Typically, feeding goes for between 8 to 16 hours, depending on the facility. So that's for continuous, or the patient may get bolus feedings, like this one, for instance. Let's look at the other video. Like this one. This patient is giving herself feeding. So this is a bolus feeding. So we can do this every, well, if it's 3 times a day, then it'll be just like how we eat. So breakfast, lunch, and dinner. The difference here will just be how many cans will the patient receive. So the doctor prescribes the amount, whether it's 1 can 3 to 4 times a day, or let's say 2 cans, right? Depending on the patient's needs again and the doctor's order. So this is called the bolus feeding. So you use the syringe and then pour it literally by gravity, just like if you were eating or drinking the solution. Without the actual swallowing, because you are giving it through the tube, whether a peg tube, a gastrostomy tube, or a nasogastric feeding. So that is bolus, and the one we just watched a little bit earlier is the open method of tube feeding. There's also the closed. The closed method is preferred because there is no bacterial contamination, or less likely. This is a failure. So here you have the commercially prepared solution. Okay, so you can literally spike the bag. You don't have to pour it into bags like this. So this is already, as opposed to pouring it out of the bag, you spike it with the feeding tube. I mean, tube feeding set, sorry. So you spike it just like an IV bag, and then you prime it. The other bag you saw hanging there was for water. And of course, the end of the tubing is not the same as an IV tubing, so you can't mistake this for an IV. So you don't inadvertently administer this intravenously instead of by a tube feeding. You know the end, right? What the end is shaped like?
Yeah.
Okay, I want to show you. Okay, so this is the aspiration of the system. But this is an old video. So at I remember this video. We used this in the early 2000s. This is from Taylor Fundamentals. At that point, there was the gastric testing the pH of the gastric aspiration was not in the textbooks yet. So that's why he returned this instead of leaving some to test for pH. Okay, so you clearly see the end of the tube does not look like a lure lock. It's not. the end of a IV tubing. Okay, it's not the same. So this one, it doesn't have a lure lock, and then it just fits into the slot at the end of your feeding tube, and it's universal. Unless, of course, the nurse spikes the bag using an IV tubing. So yes, that is already gross negligence, if not actually criminal, because that means you're giving this intentionally intravenously, and therefore you're trying to kill the patient. Since these are the only ones available in your textbook, for complications, the patient will still have high glucose levels, but not as high as in TPN. But it will, yes, it will increase the sugar levels probably by 20-30 milligrams per deciliter during the feeding. But otherwise, it shouldn't cause the same levels of hyperglycemia as in TPN. Therefore, the patient here does not need to receive insulin unless they are diabetic. Another complication is, of course, aspiration. So therefore, you must never put a patient with a feeding tube down flat. They should always be at least 30 degrees or higher, the head of the bed. Never put them flat, especially after feeding, or worse, during the feeding. Another complication is diarrhea. Because you are giving liquid solution, you may think that, oh, of course it'll get diarrhea because this is liquid nutrition. Well, how come babies don't get frequent diarrhea? How come babies who drink nothing but milk still have soft or at least semi-solid stools? Can you explain that? Are you still with me?
Yeah, organs are not developed enough for like solid food yet, so it's expecting that type of feeding, like liquid and stuff.
Well, again, babies still have, I mean, babies don't get diarrhea, right? I mean, not all the time. They still have solid poop. They have soft stools. They have semi-solid stools. So therefore, is that their correct thinking that if a patient has diarrhea, it's because they're getting liquid nutrition? Is that true?
No.
No. So diarrhea here is not expected. All right. So if a patient develops diarrhea during tube feeding, that means they're either not tolerating the solution, which the doctor can easily change it to a different formula. Maybe the patient will tolerate a different formula, but never assume that it's because, oh, it's expected. Okay, diarrhea is not expected. Is that clear? So after, let's say, the first thing the doctor will do after you report diarrhea is he'll try a different formula. So he'll keep trying, switching formulas. If the patient continues to have diarrhea, then we'll consider, especially if the scent, the odor is suspicious. At this point, you guys can already tell whether poop is regular or has some suspicious odor to it, right? Have you noticed that? After being in a nursing home or having gone to clinical? I mean, be honest. You're already aware of the different types, right? I mean, when you smell poop,
Not really. It all stinks the same
well,
to me.
that means you haven't had enough experience yet. But believe me, when you start working and then you smell these different poops, you'll be able to tell. Okay, your nose will be like a diagnostic test. You just smell it and then lick it a little bit because you can taste it also. you can definitely tell, oh yeah, I can taste the C. diff. Yeah, that's definitely C. diff, right? And then of course you send the sample to the lab and it will confirm. See, I knew it was C. diff. All right. So you guys become experts already. But again, going back to the diarrhea. So again, diarrhea is not an expected outcome in tube feeding. If there's diarrhea, it has to be documented, reported, and there has to be something done about it. So if again, if the changing formulas does not resolve the diarrhea, then consider sending the a specimen, of course, with a doctor's order for testing. Now, if the test comes back negative, then the doctor takes it from there. He may add, because let's say he exhausted his list of feedings that will, the alternates that will still meet the patient's caloric needs. If they've exhausted that already, then they consider that this patient will just need antidiarrheals. And we do see patients like that. But you have to consider infectious causes first before you resort to giving antidiarrheals. All right, so let's take a break. We'll stop from here, come back at 10:13. Take it 10-minute break.